Hello, everyone. Thank you for joining us for our second installment of the Root Cause Coalition's 2017 webinar series. Before we get started, I wanted to run through a few features of our webinar today. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of the webinar, our panelists will be answering audience questions. If you have a question during the webinar, please type your question into the question pane on the webinar control panel located at the right side of your screen. This webinar is being recorded and will be available for download on the Root Cause Coalition website later this week. Thank you all again for attending, and at this time, I'm going to turn it over to our presenters.
Thank you so much, Monique. Hi there. My name is E.A. Casey, or simply Casey. I am with AARP Foundation, and I represent our isolation impact area. AARP Foundation's vision is a country free of poverty where no older person feels vulnerable. And our mission is to serve vulnerable people 50 plus by creating and advancing effective solutions that help them secure the essentials. We're the affiliated charity of AARP, and we work to ensure that low-income older adults have nutritious food, affordable housing, a steady income, and strong and sustaining social bonds. We collaborate with individuals and organizations who share our commitment to innovation and our passion for problem solving. Supported by vigorous legal advocacy, we create and advance effective solutions that help struggling older adults transform their lives. I'm here to tell you today about our work in building strong and sustaining social bonds and share with you some knowledge about this issue of isolation. Isolation and loneliness are relatively new areas of scientific inquiry. The attention focused on these issues is rapidly increasing, though, as people start to realize what a significant and in some ways pervasive problem it is. Still, though, there's quite a lot we simply don't know yet. For instance, there's no validated and reliable way to easily assess one's risk and degree of isolation. However, I'm going to share with you what we do know and what efforts are underway to try to fill some of the big gaps in both knowledge and solutions to this problem. Prolonged isolation puts millions of people aged 50 and over at risk of diminished health. While there are no consistent methods for identifying and tracking isolated and lonely individuals, various studies now consistently converge around 20% or 1 in 5 of the older adult population, though there are very solid studies of loneliness that place it as high as 40% of the older adult population. The health risks of prolonged isolation are equivalent to smoking cigarettes and worse than obesity. Isolation has been linked to everything from early mortality to accelerated cognitive decline and beyond. Social isolation makes many older adults a prime target for scammers as well, and isolation and loneliness are increasingly linked to higher healthcare utilization and lower satisfaction with healthcare providers. Moreover, isolation touches more than simply the isolated. We all lose out without the knowledge, perspective, and talents older adults can bring to our communities. We believe the scale of this problem will continue to grow too. The number of Americans 65 and older will double by 2050. We're living longer too, and while there are many positive aspects to that, it also means that there's a growing population of increasingly frail older adults, many of whom are not necessarily financially well prepared for those bonus years. The number of older adults living alone in the U.S. more than tripled from 1960 to 2000, and independence is a deep-seated cultural value in the U.S. that makes many of us particularly susceptible to isolation. When you put all this together, we're facing the threat of a very serious public health crisis. So what are we talking about when we say isolation? Isolation is a lack of the social connection we need as humans to survive and thrive. Social connection is the quality, type, frequency, and emotional satisfaction of social ties which are necessary to support us both practically and emotionally as we manage challenges and transitions in life. Our relationships and connections to people have great value to us. Social support is comprised of instrumental support, for instance, whether we have a ride to the doctor or grocery store when we need one, informational support, whether we have someone to provide advice or help us understand when a physical symptom or cognitive change needs a doctor's attention, and emotional support, whether there are people who care about us and can share in our joy or sorrow. We need these things regardless of our age, but in many ways we need this support even more as we age and face challenges like the loss of a partner or close friends, changing physical and cognitive abilities, loss of the ability to drive, and more. Social isolation is when we objectively lack these types of support. Loneliness is the subjective experience of feeling a lack of support. A little further into that, objective isolation on the right is a separation from social or familial contact, community involvement, or access to services. We'll dive into that a little bit further in a moment. Subjective isolation or loneliness is an individual's personal, subjective sense of lacking these things to the extent that they are wanted or needed. Loneliness and isolation can be related, but they aren't necessarily. You can be isolated but not feel lonely, or you can feel lonely even when surrounded by people if you don't feel socially and emotionally connected to those people. As I mentioned earlier, there's no one agreed upon way to measure isolation. Researchers use a variety of methods, scales, and tools to try to quantify someone's level of isolation. Generally, most of those tools ask individuals about the quantity and quality of interactions with family and friends. The Levin Social Network Scale is one of the more commonly used questionnaires to evaluate isolation within an individual, and you can find it online. Loneliness is actually slightly easier to measure. The UCLA Loneliness Scale is becoming a standard around that. The full scale is 20 questions, but there's a simple 3-question version that many researchers feel is quite adequate for diagnosing loneliness. The 3-item loneliness scale asks people to reflect on 3 statements. I feel left out, I feel isolated, and I lack companionship, and to indicate whether they feel that way hardly ever, some of the time, or often. Responses are assigned a point value, and all 3 are totaled for a score from 3 to 9. While a score of 3 indicates an individual is not lonely, there's not yet consistent agreement about where the cut point should be between lonely and not lonely. One researcher's work has shown that the negative health outcomes start to present with a score as low as 4, meaning that selecting some of the time for even one of these is enough to indicate the presence of a damaging level of loneliness in an older adult. Regardless of how you measure it, the research is consistent that both isolation and loneliness can have negative consequences on an individual's health. We just aren't sure yet about the exact how and why those negative consequences occur. It's fairly intuitive, though, to see how these things can negatively impact one's health if you think about the types of support that may be lacking from a person's life. Loneliness may be particularly insidious, though, in how it operates, and so I thought I'd share with you a quote. One of the world's leading researchers on loneliness is John Cacioppo, a neuroscientist at the University of Chicago. This is how he and colleague Louise Hockley explain it. The pain of loneliness is a biological trigger, like physical pain or the ache of hunger and thirst. Hunger, of course, means you need to eat to survive. Pain sensors protect the individual from physical danger. Loneliness is a warning sign that's evolved to signal the need for change in order to restore something necessary for your survival, probably to do with protecting the individual from isolation. We have a warning system within us that triggers stress and inflammation, which then leads to a negative impact on health. So let's take a look at that impact on health. Isolation and the resulting loneliness have been linked to a wide range of poor health outcomes and higher healthcare utilization and costs. Some of the associated poor health outcomes include hormonal and inflammatory response, including raised stress hormone cortisol that Cacioppo identified. This leads to diminished immune system function and increases susceptibility to things like the common cold and leads to longer recovery time from illness. With isolation and loneliness, we also see higher rates of cardiovascular disease, higher blood pressure, increases in depression and anxiety, higher rates and more rapid onset of dementia and cognitive decline, including Alzheimer's, higher rates of admission to nursing homes, higher use of emergency services, and overall higher rates of mortality and morbidity. All of this, of course, drives up healthcare costs and drives down an individual's quality of life. So, risk. Well, unfortunately, there's not a strong body of data around this yet, but we do have some pretty good ideas. It's important to understand that drivers of isolation and loneliness can exist at the individual, community, or societal level. For instance, having a mobility or sensory impairment can disconnect you from your world, and this challenge can be compounded by a community that's not well designed to accommodate people of all abilities, as well as by society's ableist attitudes that may further confine individuals and leave them out of many opportunities for social engagement. Not to mention the failings of policy around things like hearing health that leave hearing aids uncovered by Medicare and unaffordable for too many. Some of the people most vulnerable to isolation and loneliness include those with physical mobility and or sensory impairment, those who lack affordable and accessible transportation, chronically ill individuals, individuals with low income, and individuals who live in low resource communities, LGBT individuals who may be estranged from biological family or who may have faced a lifetime of discrimination, individuals living in rural areas with limited resources, individuals with poor mental health or cognitive impairments, individuals serving as caregivers, racial and ethnic minorities and immigrants, especially those with limited English proficiency, and individuals who live alone. In addition, we believe there are certain trigger points that can increase an individual's risk for isolation, including unemployment, job loss, or retirement, serious illness or accident, especially falls, which can result in injury and lead to fear that causes additional isolation, financial strain and lack of resources, loss of one's significant other and or friends and peers, and relocation, as in moving into a care setting or retirement community. Within our work, we've looked to try to simplify major risk factors into broader categories that can help point toward clearer action. Much of the best data around what works to prevent and reduce isolation and loneliness indicates that it's important to identify an individual's particular set of challenges and then match that to the right solution. So this is our current but ever-evolving framework for identifying and understanding isolation and loneliness. As you can see, we try to categorize risk factors and drivers of isolation and loneliness into 5 main areas: transportation challenges, poor health and well-being, life transitions and role loss or change, societal barriers, and lack of access and inequality. We believe this can be helpful in thinking about solutions. I know there's a lot to take in, but don't worry. It's all available on our website along with other tools and information, which I'll come back to in a moment. But first, a quick word on ways you might be able to observe isolation in a client or patient. We do have a relatively simple and technical tool online that can help you identify risk for isolation. It has a series of yes/no questions about contact with friends and family, access to resources, participation in social activities, and more. Isolation, though, doesn't have strong observable symptoms, but these listed on the screen, similar to what you might notice from depression, maybe, might be an indicator that someone doesn't have the full social support that they need. These include boredom, disinterest withdrawal, declining hygiene, signs of home disrepair or clutter, or signs of poor nutrition. So let me now share a little bit of what we're doing to help solve these problems and what you might be able to do. As we've explored how to create and advance effective solutions to isolation and loneliness over the years, we faced a constellation of challenges. As I said, there's a lot of missing data and research. We don't even have agreement on a definition for isolation or how to measure it. much less on how to find and track people who need help. Part of it is the subjective nature of loneliness and trying to identify how much connection a person needs, especially when we all have different preferences and needs. There's also a lack of awareness around this issue. While people are beginning to recognize and name it, it's still largely a hidden problem that many don't see or think about until it has some personal impact on an individual or a loved one. And of course, there's a lack of dedicated institutional stakeholders who are focused on this issue and are building solutions. While there are many lives of isolated and at-risk individuals and who do much to prevent and reduce isolation, from area agencies on aging to volunteer and faith-based groups to healthcare providers, there hasn't been a large-scale and proactive approach to addressing this issue. We're working to address these challenges with Connect to Effect and connecttoeffect.org. We're collaborating with other organizations to address this complex issue and build an action-oriented network that creates awareness about social isolation and its impact, and creates and advances solutions. The website features tools and resources to help you evaluate isolation risk, reach out to others who may be feeling lonely and disengaged, and find practical ways to reconnect to the community. Through research and ongoing collaboration, we're also working to create a deeper understanding of loneliness and isolation, draw much needed attention to these issues, and catalyze action to end social isolation among older adults. On this site, you'll find a growing set of downloadable resources and links for all types of audiences. These resources offer everything from the latest research on the topic, tips, sheets for struggling older adults, to that assessment tool I mentioned earlier. We also have a growing database of searchable local resources that we've identified as helping to address some of the many aspects of isolation and loneliness. You can also share with us information or resources you have. If something is missing from our database, we encourage you to let us know. And if you have a promising approach or data to share, please tell us. We're here to help share the best resources and tools available, but we also invite you to help us create them. Tell us what you need and offer your solutions. We're listening. You can also sign up for the quarterly newsletter we'll soon be offering from the website. We've also just announced a new round of grant making focused on evidence-based solutions. If you have a model you believe prevents or reduces isolation or loneliness, and you're either already collecting data and conducting evaluation, or you would like to, we encourage you to apply. I've listed the website here where you can find more information. There's an upcoming informational webinar on March 15th, and you can also find details about other recent work we've funded. Many of you are probably already engaged in preventing or reducing isolation in some form, but I'll offer just a couple of final thoughts on what else you might be able to do, either as an individual or within your work. First, we all need to take an intentional approach to building and maintaining our social support systems as we age. Do that for yourself and talk to your older friends and family about it too. Get to know your older neighbor if you don't already. Don't forget that a robust social network contains people of all ages, and connecting older and younger people has huge rewards. Don't forget about technology, but also don't overestimate it either. While technology can help facilitate social engagement, it may not meet the needs of everyone. It can be too costly, inaccessible, and unappealing for many older adults. Measure isolation outcomes. If you think your work may be combating isolation or loneliness, start trying to measure that. We hope to soon offer a guide on the website that will help you, but I'm also just an email away in the meantime if you want to talk about that. Successfully addressing isolation is a both-and approach. There's no one solution. We all have circumstances, and isolated and lonely people. You have to take a look at all the barriers a person might face, from the front steps to their house that may need to be made more accessible, to the community infrastructure like transportation and other services that may need refinement, to the social barriers like for help is a bad thing. There older adults don't have skills and live contributing. We have to work on solving these problems in order to address them, but we also have to start imagining new solutions. People fundamentally need social engagement and a sense of purpose, no matter their age. For most of our lives, that social engagement and sense of purpose is primarily supported through our jobs and our families. As people stop working and sometimes lose family and friends, we need to offer alternatives that continue to create new opportunities for older adults to make friends and find meaning. So thank you so much for your time and attention today. I hope this has helped you better understand this emerging issue. I welcome all of your feedback. I look forward to your questions at the end here. And again, I appreciate your interest and any work that you're doing in this space.
Karen and Shirley?
Okay, thank you very much. Today, Shirley and I are going to present some of our work that we've done at UnitedHealth Group. My name is Karen Keown, and I am a former nurse, and I've been at UnitedHealth Group about 25 years in various capacities, and most recently have been working with disparities and looking at social connectedness and loneliness within our Med-Sup population. So just with some background, if you're not familiar with UnitedHealth Group, we're a Fortune 6 company. We're primarily, we started in the insurance business, and we manage Medicare, Advantage, Medicaid, commercial, and employers. And we have a relatively large division called Optum, which you may be familiar with, that has a variety of businesses that support changes in the delivery system. From the Medicare division, there is a group that manages Medicare supplement, which some of you may know as Medigap. That basically a member pays a premium to cover copays and deductibles not covered by Medicare. So we have about 4 million, close to 4 million Med-Sup members that are managed by UnitedHealth Group. It's a branded AARP product. And so that's what most of the work that we have done, Shirley and I, has been around this particular area. It just is also sort of a background. You know, most of the program efforts at UnitedHealthcare and other insurers out there, Aetna and Cigna, have really been focused on the improvement in clinical care and the management of medical costs. There's been a very sort of traditional managed care approach that entities have taken in the market. However, we see that changing now. We see folks like Mark Bartarelli on an interview talking about social determinants, the first time you've ever heard the CEO and chairman of Aetna talking about these kinds of things. And loneliness has become quite a talked about topic, and how that affects healthcare costs, which lonely people have significantly higher healthcare costs than people that are not lonely. But really, this was a lot of the work that we started in loneliness back in 2012, and that was really with our partnerships with ASI, Charlotte Yeh, and team, who really encouraged us to look beyond sort of what traditionally we did in managing medical costs and look at other dimensions that really affected healthcare services, and quality of life. And one of those factors was loneliness. So we wanted to share with you today the survey results around our Med-Sup population and give you some insight as to the types of pilot initiatives that we're currently conducting to improve loneliness in our senior population. So this is something that Shirley put together, this poster session that was accepted, I think about a year ago. And so I'm going to kind of go through this, and then we'll certainly take questions at the end. And I'll describe at least 3 of the initiatives that we're doing right now as a byproduct of some of these results that we have surveyed through our membership. So when we looked at the objectives, I mean, it was really to estimate the prevalence of loneliness, and I appreciate all of Casey's background on that and her, her information, because our data really sort of lines up very nicely with some of the data points that she had as well. For our MedSup insured, again, about 4 million people that were eligible for a program that we run, which is a care management program for our frailer and more elderly patients that are in AARP MedSup that have multiple disease conditions. So we identified these people through a combination of a poor health status that is self-reported and selected diagnosis codes. And our objective was to identify the characteristics associated with moderate and severe loneliness. And then we also wanted to understand from the business perspective what their satisfaction was with the AARP MedSup plans, the providers, which this is all open access. These are Medicare fee-for-service that are buying supplemental plans, and overall health care. So what some of the background, I think it's interesting because, Casey went through some of this background in terms of, loneliness affecting older adults, but it is not unique to the older age group. And in fact, I know, we've looked at some of the literature that some of the loneliest people are freshman college students who have gone away from home and who no longer have that family social support, yet they are surrounded by many people on campus. So it really is not unique to old age, although when you take a look at some of our data, we'll show you how it increases in terms of prevalence as someone gets older. And our data also indicates, as Casey had mentioned, that loneliness is associated with depression, poor health status, disabilities, and decreased quality of life. And we'll show you a little bit of the work we did around mental health issues as well, and how people generally with mental health issues are often associated with a dissatisfaction in healthcare services. So we surveyed, again, it's a Medicare fee-for-service with, probably most people know it as Medigap, but it's MedSup, and that was about 4 million people that we have currently insured by UnitedHealth and a branded AARP product in 50 states, DC, and U.S. territories. In this study, loneliness, patient satisfaction, and quality of life, as well as demographics and health status, were self-reported by the CAP survey. And many of you may be familiar from the delivery system of the CAP survey. It's used very widely in the delivery system, both hospital and physician delivery systems. So we use the CAP survey as a standard. It's really considered the gold standard of measuring consumer experience, not just with their health plans, but also with their providers. So we used the CAP, and we collected it from individuals in 4 states, North Carolina, New York, Ohio, and Texas. Those happen to be very large states for our MedSup population. In 2014, there were 65 and older, self-reported poor health, and had an AARP MedSup plan. Casey's already gone through this, and it was a great lead-in, has already gone through the UCLA 3 scale. That is what we use as the standard, and we measured against that scale. And that is, again, how often do you lack companionship? How often do you feel left out? How often do you feel isolated from others? And those are the questions that we used. Quality of life was measured using the VR12, similar to an SF12, if those of you familiar with that work with John Ware. But it's the VR12, and it's a scale that really takes a look at both physical and mental health components. So we took a look at that, and that's some other data that we'll show you here. I'll kind of probably skip through the statistical analysis. I'm sure for those of you that love that, I'm sure that Shirley would be more than happy to answer a lot of questions around the statistical analysis, and maybe we'll just put at the top of the screen Monique, and then look at the results. Yeah, we can just kind of scroll over if we can. Great. Okay, so this perfect. So this was the results of the prevalence of loneliness among the AARP Med Self-Insured 3765 survey responders. And you can see, the not lonely, 46% were self-reported as not lonely, or based on the, based on the UCLL scale. But you'll see of severe and moderately lonely, a very high percentage of, especially within the severely lonely, at 28%, and 27% being moderately lonely. So 55% are reporting some level of loneliness, which I think actually was surprising that those numbers were so high from our perspective, and it really sort of reinforces the attention that we need to give to this issue. If you can scroll down a little bit, Monique, we'll go to the respondent demographics. Perfect. Okay, so we looked at this data in sort of 4 different quadrants. We looked at gender, and as you can see, males tend to be less severely lonely than females. And then we have sort of an increasing percentage of females that are severely lonely. They're likely outliving their spouses, outliving their friends. So they really are probably the lonely or more often female, older, poorer health status, and are depressed. And when you look at the health status, direct correlation with people that have a fair and poor health status with those that are severely lonely. For the age group, you can see the demographics on the age group. Again, people that are in that younger cohort, that 65 to 69, much less issue with loneliness. They're much more socially connected, probably much more active. Those people that are 85 plus, as you can see, that gray bar on that 85 plus, a significant amount of people at 85 plus being severely lonely. And as Casey pointed out, depression is really is a condition associated with loneliness. Whether depression causes loneliness or loneliness causes depression, that would be a question. But clearly there is a very high and very strong correlation between depression and loneliness. So if we scroll over, and up a little bit if we can, perfect. Okay, so these are some of the characteristics associated with loneliness. The things that are, 1.00 to 4.00, those odds ratio, the values greater than 1.0 are things that are more likely to be associated with very lonely. So again, we have depression there, very, very strong correlation with loneliness. Those that we actually measured, those that were disengaged from our care management program. So those people that we were not routinely connecting with tend to be obviously more lonely. Vision and walking problems, female as we saw in that previous data, hearing problems, urban location, and some of these other pieces, the risk score and first dollar coverage, that's more involving what kind of plan they have and what their risk score is in terms of their severity of illness, and you'll see a negative correlation with high health literacy. So the strongest predictors are for severe loneliness with depression, along with poor health status and disabilities, vision, hearing, and walking. So we describe the VR12, and these are the results from the VR12, the physical component and the mental health component. And I think, the physical component, you're going to see, you see some deterioration in the physical health component, but significant reduction in the mental health component associated with people that are lonely. So, up from the, from the top of the right-hand side of the picture in terms of mental health components, but you can see the deterioration in mental health components is very significant in the severely lonely. The last piece on this, the bottom here, is, if you can scroll up just a little bit, is really more of the business side. As I indicated, we were interested in also understanding, does this affect their satisfaction with our health plan? So this was the data that we pulled to sort of say, okay, what are the correlations with decreased satisfaction with our health plan? And it definitely correlates with severe loneliness. Strongest predictors of people that were dissatisfied were really the severely lonely. And the predictors of patient satisfaction with their doctors and healthcare were similar data. So the severely lonely are dissatisfied with whatever services are provided through this type of a product, as well as the services that are provided with their doctor and healthcare. So if we scroll over and up, okay. So, in conclusion, I think we were struck at 55% of our membership that we surveyed reporting moderately and to severely lonely. We think that is significant, and as Casey pointed out, it really is considered a chronic condition that is more prevalent than obesity, cardiovascular disease, diabetes, and that the strongest predictor of loneliness was depression. We know that it's female, it's older, having trouble with vision and hearing, where they can be isolated, and trouble with walking and balance. The few characteristics that were protective with high health literacy, and it had a factor on what kind of actual med sup plan that they had that they were purchasing from us. The results for moderate loneliness were similar. We haven't shown you that data, but severe and moderate loneliness decreased the quality of life. You remember those physical and mental health scores, and was the strongest predictor for dissatisfaction sort of with our plans. So given that, what are the implications from this, and what are we doing as part of, we're a group called Healthcare Transformation that works with Charlotte Yeh and her team from ASI to do pilot programs to see if we can make a change in loneliness, if we can move the needle in loneliness, and what types of things that we can do. So we do have various surveys and various screens to understand who is lonely out there. We just actually ran a campaign, an IDR campaign, that's coming in right now in our Texas market, 110,000 people through an IDR campaign, and we will probably find anywhere between 5,000 and 7,000 lonely people in that group for us to target, because there's only a certain amount of people that actually answer the IDR, and then it's about 20 to 30% of those people will be isolated and lonely. So we're actually doing a campaign in Texas to identify those people. And so I just want to kind of give you a little bit of a flavor of 3 different programs that we're running for loneliness right now. And we've done some things around reminiscent therapy in the past, in 2012. We're expanding that work in loneliness in 2017 to work with a company called LifeBio. It's lifebio.com. And that company basically allows a senior to create their autobiography. And we're going to measure the pre and the post associated with that using a standard measurement tool to see if we can improve their loneliness level by putting them through a program, and it's actually a 6-week program. We're going to be running it telephonically, like a teletown hall, and it allows people to have a workbook, and then they answer questions and they participate in these calls and share their information and share their stories. And what it does is it generates for them an autobiography at the end that they can share with their family and their friends to sort of leave their legacy behind. And there is information in the literature to indicate reminiscent therapy does improve the mental health status of people. It certainly does in the area of Alzheimer's and those kinds of things. So the kinds of questions that they ask at this exercise, one example is, what is the greatest invention that has come along in your lifetime so far? Why was this invention important to you? And then, so they journal this information, and then they share it with the group, and at the end they have a complete set that they can then sit down and share with their families. So that's one intervention we're doing. A second intervention that we're looking at is called problem-solving techniques. And this involves contacting someone that's socially isolated. They may not always have been lonely. That may have been an occurrence where maybe their spouse died, or some of their other good friends have passed away and they no longer have connections out there in the community. And it's about doing one-to-one goal setting with these members, and it's very similar to cognitive behavioral therapy, if those of you that have a mental health background out there. But it really just looks at how can you set goals to get yourself out and connected again with your friends in the community. So we're actually doing two different bifurcated arms that we'll be doing this year. One is a telephonic version using a trained clinician to take you through that problem solving, set goals, check in with you, see how things are going, reset goals, using a reward system of just positive reinforcement. And then the second is going to be actually a web-enabled chat with a peer-to-peer support. So not using someone that is a trained peer-to-peer, but not using a clinician, and doing it as a web chat. And we have looked at our data on the messed up population, and especially within the bands of 65 to 75, 89 to 90% of our messed up folks are web-enabled. So we're always looking for scalable solutions that can be accessible to a number of people, but we're also cognizant that there are people that are not web-enabled, or some people that might respond better to that one-to-one telephonic coaching. The third initiative that we're running this year is to test the effect of robotic cats and dogs on loneliness. And if you look on the website, you'll see, I think there's a number of companies that do this. Hasbro is one of them that produce these robotic pets. And they, the cats, for you that are cat lovers, they purr, they roll over and let you scratch their stomach, they meow, they raise their head when you come in a room, and they probably sleep 16 hours a day like my cats do. But they have very real fur, it's very natural fur. And Hasbro actually has tested this in actual skilled nursing facilities and had some very interesting results. So we're going to be doing a pilot to take a look at, can we reduce loneliness in that population, and also we're going to be looking at a second cohort is, can we reduce the stress for caregivers, and can we reduce caregiver loneliness as well. So those are just some of the things that we're working on around loneliness, and be happy to take, I don't know, Shirley, if you've got comments that you think I've missed in the presentation, feel free to chime in.
No, I think you did a good job of summarizing it. So maybe we can turn to questions, if there are any from the group.
I haven't seen any yet, but if you guys have any questions, we'll give you a minute or so to type them in on the questions pane, and we would be happy to answer them. Okay, we have a question from Jeanne, and her question is, what is a good website or websites to look for research or evidence-based practices addressing loneliness or depression in seniors?
Casey, you're probably the best on that versus me, I would think. Do you know resources that have been aggregated, Casey?
As far as I know, there are not any good spaces where things are aggregated. There is, so we are working to an extent to build out some of that set of resources on our website, but it's still a work in progress, but that's connecttoeffect.org. In the meantime, I think one of the best sources to take a look at
Hey, Casey, your microphone is cutting out a little bit.
okay. I don't know exactly where my microphone is. Is this any better?
Yes.
Okay. One of the best spots to get data is the UK's campaign to end loneliness. The UK is taking a really proactive public health approach to addressing loneliness, and campaign to end loneliness.org, I believe, or if you just Google UK campaign to end loneliness, they have quite a bit of solid data and information and ideas available there.
I might add, one of the reasons that you have difficulty finding resources are that I'm not sure that people know exactly what to do about loneliness. There certainly is no clinical solution. There are clinical solutions for depression, for example. It can be diagnosed, and there are medications that can be used to address depression as such. Loneliness, not so much, and so doctors don't know quite what to do with loneliness, so they usually don't ask the question, and even when we do understand that people are lonely, the solution for those people is various and not standardized, so it makes it difficult to know exactly what to do.
Great. We have a few more questions. This one comes from Deborah, and Deborah asks, in the IVR campaign, what screener was used to identify loneliness?
We used the UCLA 3 questions, and it's part of a broader question set that is, I think, about 23 questions called the Health Check-In that we do, and we ask a variety of questions about health status, caregiving, resource support, and the loneliness questions are part of that campaign. And that really goes out to for now, in some of our new states, it goes out to all new members of Health Check-In, and in some of our other states, it goes out to a selected group of our population.
Great. The next question comes from Tina, and Tina asks, do either of the presenters have any information on the effectiveness of telephone reassurance programs versus in-person visiting programs?
Well, we have done, I can tell you that we have done, and we have data on in-person and changes in loneliness. We're using community health workers in a couple of our markets. And, you know, these community health workers were, their job, it was really sort of managing social determinants and connecting people with community resources. But what we found is even if they didn't connect them with community resources, we saw a change in the loneliness level. And so that community health worker program is showing But that is a combination of telephonic management and in-person management, so that we're currently doing. And that's the only thing I'm aware of. Casey, you may have some other data points on that.
Yeah, I can't think of any specific comparison of telephone versus in person. I will, and again, that goes back to there has been really limited data and evaluation collected around this issue. But some of the research that exists, and this is available through the UK Campaign to End Loneliness site, actually, suggests that group-based approaches and participatory approaches are more effective than one-on-one based approaches, that finding ways to bring older adults into groups there's more there are more returns to that than simply connecting an individual to another individual.
I can add just one other bit that speaks to this, not directly but indirectly. There's a Dr. Choi at the University of Texas in Austin, where she works with Homebound, and she's done it both ways, using tablets with Skype and then in-person visits. And once older adults get over their reticence in using technology, they love the technology to the point where they preferred the meetings be done via technology rather than one-on-one to the home. Some of it is they don't have to clean up their home, they don't have to worry about what they're wearing, and they can set up the appointments at a convenient time. So, and there's more flexibility in that. So there seems to be a lot of opportunity in technology with older adults, and so I think we're just getting to that, and particularly with phones, we're seeing a familiarity with smartphones and the willingness to use technology, which we always were hesitant because the concern was that older adults didn't have computers. Well, you don't have to have computers now. If you've got a phone, you can work through the phone, or if you've got an iPad, you can work through the iPad, and it's gotten more user-friendly. So I think there's a lot of opportunity in technology.
So Shirley, in that study, were they just then comparing patient preferences versus?
Yes.
Okay, patient preferences.
Yeah.
Okay.
Yeah, they were given the options, and again, with the homebound, the idea of a person coming to the home and visiting, at least to the researchers, seemed like that would be the preference. But then they had Skype, so they actually could see the person on their tablet. But they overwhelmingly, as they got into the sessions, preferred the technology.
Yeah, and I think Nancy Choi, correct me if I'm wrong,
Yes.
Shirley, she's done a lot of peer-to-peer work too, in her model, sort of the pay-it-forward type of thing, versus just offering support versus sort of a clinician or clinical group.
Right. I mean, she just does a lot of problem solving that you mentioned. So it's a lot of problem solving. It's like, what is your, for homebound people, they have they have a unique set perhaps of issues that they have to deal with. But whatever the problem is, it's probably unique to that person. So again, that one solution isn't going to fit all people, but if they can learn to problem solve and work within the environment that they have available to them, then they have. And her outcome was depression, lessening of depression, and she found that those sessions, again, when you have some control over your environment in problem solving, it lessens depression.
And just a quick follow-up from that question, is any of this research publicly available?
Well, this study that you're looking at right now is published. So this is available public. It's an open access article. So that article would be is certainly one that is publicly available.
Great. Just a few more questions that we have time for. Can any of you provide some color around how you identified individuals that were at risk of being lonely or socially isolated?
I can talk about that.
Go ahead. Go ahead.
I can talk about that very quickly in terms of our work. We have primarily worked with community partners and let them really identify within their client base who is isolated. Because I think, as you're hearing, there are such a myriad of kind of causes and drivers, but it is to an extent something that you kind of know when you see if you're working closely with a client. So we have really relied on, the social workers, the in-home supports that people have to really point us towards the people who are most in need of help.
And we primarily have been identifying it through surveys, through our various surveys, and including what we call our health check-in, which goes out through interactive voice response. So we're identifying it as more of a survey. We're not connected with any sort of delivery system, and we're not connected with any networks being messed up. So getting referrals from the delivery system isn't really an option for us. We do surveys to our members, to a number of our members for a number of different reasons, and we've got a number of clinical surveys that we send out for our membership on a regular basis. So that's how we're identifying these folks.
Great. Christine asks, was the self-reported fair, poor health scale age adjusted?
Shirley, can you answer that question?
In the demographics that you're looking at, no. In the up above, in the on the graphic that's on the right upper quadrant of the results, that is a logistic regression. So when in that's a regression model. The demographics down below is not adjusted. That's just straight up. This was a fairly narrow broad band and they were qualified for the care coordination program, so they were all at some level of poor health. But you can see the age range was mostly older people, and although it included all people across all ages.
Right, and our final question for the webinar, did you look at marital status or financial status of participants in the study?
A marital status, no, we did not have marital status on the survey, so we didn't have marital status, but we had, we don't ask income on our surveys, but we use what we call geocoded from your zip code. It's based on where you live. And there are formulas to determine income bands, not precise income, but income bands based on the zip code of where you live. And we use that as an adjustment in our models.
And from the MedSup perspective, we tend to market and secure a more affluent group who tend to have a higher income. So, especially in certain markets, we have a very high percentage of affluent that buy our product.
And I'll second that. So it makes the diversity in this is less in this population when it comes to income compared to like a Medicare population that would have a broad band of older adults that would be typical of the U.S. Those that that purchase this particular products tend to be middle and upper income brackets.
Great. Well, thank you so much, everyone, for asking questions and participating in the second installment of the Root Cause Coalition's 2017 webinar series. I want to give a big thank you to our panelists today. And at this point, our webinar is now over. Thank you so much.